Okay, let's make a start now. So, welcome everybody. I'm assuming you can all see my screen. Can you see my screen?
Yeah.
Yes.
Okay, fantastic. So, welcome to this webinar on the new normal for Locum GPs. Thank you to our guests for taking the time out to prepare and come for this webinar. And thank you for attending. We were overwhelmed with the response. Actually, we got a very large number of registrations, and we had to keep bumping up the Zoom subscription. So thank you very much for attending and coming along. So in terms of the schedule for today, what we're going to do is we're going to have an introduction to the event and a set of polls to understand the mood, understand kind of the views of GPs. While we're doing that, I'll introduce the panelists and myself. We will have a four-way discussion with the panelists, followed by an interactive discussion where you can raise your hand, get involved by raising your hand, or submit a question on the Q&A feature of Zoom. We will have closing comments and then finally a closing poll. So to get started, I want to get the poll started up now. And I'm going to launch the first one. So if you are a Locum GP, please do get involved in this poll and it will help us guide the discussion today. So there's many of you responding now as we speak. So while those polls are completed, I'm going to go and introduce our lovely panelists. So we have Dr. Nighat, who is a family GP, a Locum private GP, specializing in women's health and family planning. She is also a BBC radio and TV contributor. I've seen her actually on TV myself. And she's based in Buckinghamshire. Dr. Jagan John, he's chair of Barking and Dagenham CCG, urgent care lead of North East London, COVID lead of North East London, and personalised care clinical lead HLP for NHS England. He's based in North East London. We have Dr. Sarfaraz, who is an urgent care lead and associate managing director. And we have Rachel, who is Rachel Mcmahon, who is a Locum GP, LMC secretary, a member of sessional GP committee within the BMA. So definitely somebody who would love to hear your views because she's representing, she'll be representing the views of Locum GPs to the committee. And she's from Middlesbrough. Of course, this is just a brief introduction. There's much more to the panelists, and I don't mean to do any injustice to them because they have fantastic CVs and profiles. On to myself, I am the founder of Pairoo.com. I'm a former Microsoft worker. I am a cloud platform and big data specialist. Not that much in healthcare. I've only been involved in healthcare the last few years, so still getting the ropes. And then I founded Pairoo in 2018 to try and bring a technology revolution to recruitment and workforce management in the healthcare sector. So we've had now 51 of the 69 responses. I'm going to end the poll and share the results with everybody. So this will definitely help guide the discussion. Everybody, all the panelists can see the response, yes?
Yes.
Mm-hmm. Yeah.
Okay. So let's make a start with the panels. Dr. Nighat, as a Locum GP, what are your thoughts on the impact of COVID and being a GP going forward?
I think it's undeniable that the impact of COVID-19 has massive effect on how locums work, from childcare issues. I find that particularly difficult being a mum of 3 children, to finding work, because especially as in some general practices, the work actually became less due to video and telephone consultations, and the salaried and the GP, the partners at the practice, were finding that they could cope with their workload, and therefore hiring locums was getting more tricky for them, and because they didn't need it, which was understandable. Then also, I think that a lot of Locum GPs, like myself, I work as a portfolio GP, so there's a lot more to what I do. I teach VTS students and medical students, I also write stuff. I'm on social media. I do BBC stuff, and I think that that's the way forward. That GPs who have a portfolio career, that in general practice, that they will come with their core skills of being a GP, but then also those portfolio skills will also be paying into effect, and that's a positive thing when it comes to general practice. In locums, when it comes to demand on on appointments, well, COVID-19 has meant that the demand on appointments initially was actually very less because 111 took over. So, and the role of telemedicine is going to be huge, and that's just going to get more and more. So the impact of COVID-19 is big, but I think that this is a positive thing. It means that we can adapt. It means that the way we work is going to be a little bit different, and it shows that what we're capable. If I think back, I tried to get a wooden table, electronic table, so I could do bimanuals and smears. It took me 6 months, and telemedicine came around within a day. So I'm very positive that I think this is a time for change, which is fantastic.
Excellent. Thank you very much, Dr. Very, very brief and very concise answer. Dr. John, what changes can GPs expect in the coming days and months as lockdown eases and the new normal commences?
Thank you. Thank you for that, Hassan. So a lot of the stuff that my colleague Nighat has said is actually absolutely right. I am positive for locum GPs, and let's not underestimate, and I'm sure colleagues on this panel will probably say, of the impact of locum GPs are, you know, across the system. We need them. You're not going to go anywhere. We will still need you. The workforce is it is a huge asset to the workforce of having this flexible workforce across the system, particularly with these changes. But to answer your question, Hassan, we are currently in the process across all STPs, and that's the and CCGs are looking at the recovery process, and that is not only in primary care but hospitals going forward. You will see in the next couple of weeks, and it will be weeks, in line with very much what the government is saying, that GPs will be opening up a lot more face-to-face consultations as we speak, particularly on chronic care. I mean, one of the biggest issues and impacts has been the impact it has on chronic long-term conditions, as well as those cancer cases and all this. And we've got some really horrible data that just says, actually, we've got a huge ballooning of work coming our way. And currently, I mean, in my practice of around 24,000, we are really struggling with appointments. We've just suddenly, and I've got locum GPs as standard in my practice, and certainly we didn't reduce at all in our, and there was a time where we would question to say, well, you know, is there demand? But the demand is coming back, and I do think that the system will require locum GPs to come back in to do some work. But I also agree with Nighat's points about portfolio GPs. There are massive opportunities where hospitals won't be able to cope with the numbers of stuff coming in, and there will be movement of work with the post-discharge patients, you know, in terms of traditional general practice, going back into the community as such. And CCGs are now planning to say, how are we going to increase, you know, this GP workforce to support the systems? In my patch, you know, there's a traditional, we don't have enough GPs, and we'll be looking at different ways of bringing that in. But again, as Nighat mentioned earlier, I do think general practice has changed. It has changed permanently. Let's embrace the fact that actually video consulting and remote working is going to be the norm. It's not just us, it's the whole hospital system. So we've got to remember that there will be opportunities for flexible working for people like Nighat, who are trying to do the school run and trying to do all the things that she has to do. And actually, she could do it all because there is a lot more flexible working, rather than you've got to be in a place, you've got to be, you know, in a particular area to achieve all of that. Of course, it depends on lots of things like laptops and all these other things that you will need. But I do think that the underlying point I wanted to say is, A, the demand is going up across the system. We need GPs more than ever in any form. regardless of whether it's local, sessional, you know, speciality, whatever you want to call it. We will be flexibly working, and general practice will be, you know, looking at systems to say, well, you are locuming for me, but could you do it, you know, where they say they can't do it, they say, well, could you do it from home? You know, there'll be options, those kind of options going forward. And then thirdly is, and I'm not going to take steam from my colleague, Dr. Munshi, but there'll be other opportunities in wider systems, urgent care, 111, but I'll leave that to him to say there'll be other opportunities where we need locum GPs, particularly in particular areas going forward. And the reason why I say that is because of infection control is a big problem for everyone in trying to sort that out. And general practice changing is sometimes, I would argue, that would probably be the general practice or primary care version of how we deal with infection control. You know, working from home, not having too much footfall, and only seeing certain cases.
So very quickly, just to follow on, if you look at the result of the polls, the biggest kind of concern is the future of locum work and the current demand. Is how soon do you feel GPs will start to see that the work returning somewhat close to normal?
I think it will never be normal. I just want to make that. I mean, if I look at the NHS England primary care kind of documents that I've seen, it will never be the same, but the demand will be there. And I think in the next 2 to 3 weeks, we're going to see a massive shift. And whereas locums weren't being asked, or as Dr. Arif has said, you know, it's not, they weren't requested, they don't need it. I think that demand will change completely. So if you're asking, the short answer is 2 to 3 weeks. Come November, when we're expecting possibly another break of COVID again, I think things will have changed. But we've learned a lot. What we've done previously, where we said no locums, no locums, I think that would change quite differently in November. It won't be no locums. We'll embrace them a little bit more. Remember, this is a pandemic, the last 100 years. We've learned a lot. And we did things not necessarily the right way the first time. The second time is about doing things. So my view as a chair and as a lead for London, I think locum shouldn't be worried. I think the opportunities will be coming.
Excellent. Before we go into the next panels, just to remind everyone who's attended, the Q&A feature you can use to submit questions, and they are anonymous. So we don't need to worry about putting your name against them, and we will assess the questions individually before putting them to the panelists. Dr. Rachel, how soon do you see demand picking up? Do you kind of agree with Dr. John there, or have maybe a different view? And as you're the only rep outside of the South, you're up north, closer to where I am from, are there any regional differences that you may be aware of?
Yeah, I'm a bit less optimistic, actually, sorry. I've spoken to my colleagues on the sessional committee, because we represent across the whole UK. There doesn't seem to be huge regional variation. It seems to be quite stable across the whole country. And what we're seeing is that demand for locum work has fallen dramatically, and locums are really feeling that. And I think that was really reflected nicely in your poll. So I think what we've heard is the same as what the participants this evening are telling us. And as part of that kind of disengagement, we're really seeing disengagement of locums as a result of that. They're feeling very marginalised. They're feeling very much on the edge of general practice at the moment, and that's a real challenge for general practice as a whole. There's definitely an upswing at the moment in locum demand, which is great. There's an upswing in patient demand for absolute certainty, but there has been a real change in how services are delivered at practice level, and I'm not at all clear whether locum demand will go back up to where it was. I think it absolutely won't, because I think practices have become really inventive in how they are managing demand, and I think they are looking to manage things differently. The days of people coming in to just get things checked over because they want to, I think, are well gone, and there's a lot of resistance from practices to going back to that. The other thing we've got to be really aware of is that practices are not, certainly in my area, practices are not doing well financially. There are a lot of practices that are really struggling. Budgets aren't going up, demand is going up, but budgets aren't going up, and they just don't have the money to be able to pay for locums in a lot of areas. And so I'm being a bit more negative, I'm sorry, but that's just how I see it. I think the big kind of upswing for us though is staff leave. So staff generally haven't had any leave over the last 3 months. There's been an absolute moratorium on people going on annual leave, and people are starting now to want to go on annual leave, and that's a big opportunity for us as locums. There is, of course, people still having babies, so there's always going to be a need for people having maternity leave. There's always a need for sick leave cover and all of these sorts of things. So I think there always will be a need for locum cover, but I think it's absolutely going to be less than it ever was. So I think probably a better question is actually what can locums do to help themselves to try to maximise the work that you're getting, rather than kind of thinking about what's going to happen. And I think absolutely being as flexible as you can, recognising there has been a change in practices, so in the way practices work. So thinking about what can you offer to practices, what are you prepared to do, keeping your skills up to date in telephone consulting, video consulting, what is it that they actually require of you now in the new world, not what did you used to do before and that's all you can offer. Make sure it's always safe, so be aware of your particular COVID risks, especially if you're in a vulnerable health group, or any other particular COVID risks that you need to be aware of, and update your locum terms and conditions if required to reflect this, to make sure that you maintain safe working practices and you protect yourself from any sort of exploitation. I think you should review your fees. I think actually fees have been too high. Practices would say they're too high. You need to look at them, particularly if you're reviewing the services you're offering to locums. Make sure that you're offering them good value for money. When you go there, make sure you do a good job and be nice to everyone who's there. Even though you're being COVID safe, keeping social distance, it doesn't take a lot of effort to be really nice to the receptionists, to the nursing staff. Those are the people who put in a good word for you and get you back with more work there. So getting regular work from the same practices is always a good thing. I think there will, as I said, I think there will be a long-term reduction in demand. I would advise people to really think carefully if locum work remains the right thing for them, because I think there is likely to be some more tough times ahead. So consider why you personally work like this. Why have you chosen to be a locum? Is that still right for you in this new COVID world? And should you still be working like this, or should you be considering other options? If there's another dip in the market with a second peak, people talk about second peak like it's a good thing, but what happened in a second peak is that demand practices went down. So if there is a second peak, I think we should expect that that will probably happen again. CCAS will be reopened and hospitals will be reopened. Patients will stop coming to practices. So I think we should expect as locums that if there is a second peak, there will be another dip in demand. Can you personally cope that dip in demand? Do you have the financial resources to be able to cope with that? Now is the time to look at that and to consider how you would manage that. Look at your finances, look at what savings you have, what outgoings do you have, can you manage that better? And as Nighat said, taking this opportunity to diversify your income streams, try to look at where else you can earn money if there is another dip in the market like there has been. Those would be my recommendations.
Thank you, Rachel. Very insightful outlook on things. On to Dr. Sarfaraz, last but definitely not least. A lot of locum GPs were working in out-of-hours and urgent care settings. Tell us more about how those settings are adjusting and what locum GPs can expect from those settings in the coming weeks and months.
We've got, I'm the urgent care lead, associate medical director for urgent treatment centres in East London. It's quite interesting because during the peak of the COVID, we very quickly adapted to how we ran the front door of two busy hospitals. We then saw a massive decline in demand. So we went down from 300 cases that we were seeing in the urgent treatment centre right down to 45. We're now back up to about 220 to 230 a day. But I wouldn't say that's the norm throughout the system. I think we've got more demand than other hospitals. So it's difficult to come after my colleagues because, I mean, they've added a lot of value in what they've said. I work with Jagan in the system, in the East London system. I think it's in the urgent care setting. I think the real question, if anyone works in this space consistently, the question you've got to ask yourself is, if the ask is that you're doing primary care in the front of a hospital, and we've now got a pandemic, and everyone's asking, why is primary care still in the front of a hospital? And they're talking about moving it out. Then how does that affect you in your locality? Now, I'm going to slightly change that and say what we've done locally to protect, to make sure that we're still relevant in the system. So we've acted as the gatekeeper into the hospital. So in terms of 111, how can we support the 111 system? So our GPs now, for example, are now sitting at the front door, and they're making strong decisions. They're strong decision makers. So what Rachel touched on there was, you know, what can you offer in these difficult times? So we've got GPs who will work from the front door, see and treat. They will make referrals to SDEC. They will manage the workflow into the hospital. And something that's really important, and something we've been touching on in our system quite a bit, is how do you work at the top of your clinical license? How do you improve your outcomes? Because this is things what providers are now looking at. They're saying, well, if we're spending this much money on a locum GP, what are the outcomes? I think it's something we didn't really ask for a long time. And that's happening. As an urgent care provider, I had to ask myself, well, what are we going to offer that's more than primary care? So we've integrated diagnostics. Well, we've integrated radiology already. We've already done our pilot with point of care testing. So we've moved away from the primary care model and moved further ahead. We're now going to start offering more virtual assessments in the urgent treatment centres to help support the ED and the wider system. But I guess I've got a question for the rest of the panel at the end of that. And that's this, that I've seen quite a lot of patients that have come into the EDs. I've seen a case today, and there certainly is a lack of chronic disease management. So how is the chronic disease management going to be different? And to what extent will locum work then recover? Because that work, I agree with Rachel, but I also agree with Jagan that that work's going to come back. But in what form is it going to come back? How is it going to be delivered? How much of the chronic disease register is going to be digitalized? And I guess that might shed some light on how that bit, how the locum work in primary care might recover. In terms of urgent care, I think you need to look locally and say, what is your provider doing that's more than just primary care? That's the question you've got to ask yourself. If they're not doing anything more than primary care, I can't see how they're providing any significant value in a pandemic. And that's what we've done, and we've rapidly adapted our model to address that.
That's why I think that being a portfolio GP, so finding what you can offer to the practice is going to be the way forward. What you can offer, what skills you can bring. Can you do implants? Can you do coils? Can you manage asthma? Can you manage diabetes? I think that is where locum work is going to progress into, which is really exciting because it means you can learn new skills.
Thank you very much, guys, for the panel discussion. Now, we have a lot of questions which have come into the Q&A section. I don't know if you can see them all. I can, I think the panelists can as well. We have now the opportunity for you to raise your hand and get involved in this discussion. So can I ask any GPs who want to be involved and make some comments now or ask a question to do so now? In the meantime, I have one question which I would like to direct to Dr. Nighat because it's about private work. Now, you're involved in private work, if I'm not incorrect.
Yes, I am, for the last 5 years.
Excellent. So the question is, can someone point exact steps into setting up a private GP work? Is it something that's, I guess, suffering right now more than other work in any case, or is there any, where do you see private work going in the coming?
So I actually think private work will get more because the demand, people are becoming more invested in their health. They want to look at more preventative care. So I'll just give a little synopsis of how I came into private work, because I think that's going to be the best way. I never set out to be a locum. I was a salaried GP, 6 to 7 sessions a week until 2015. My son ended up getting liver cancer and needed a liver transplant. So my world fell apart. So talking about readaptation, this is what I've done. I've had to readapt and come into locum work in order to sustain my income, keep myself skilled up so I can have my appraisal sorted and revalidation, and as well as actually become a portfolio GP and do the array of things that I do in order to balance that with my childcare. Private medicine is going through the roof. It's going exponentially because they were investing in telemedicine before even the NHS was there. So I was using video consultations and telephone consultations before EMIS, that's what I use locally, was doing. And also what they're able to offer is far more. People want to have a quick appointment with a dermatologist, a neurologist, and orthopedic surgeons because they're difficult appointments to get in secondary care. So there is demand for it. But when it comes to private medicine, it's all about what you bring to the system. What do you bring into the practice? It's not just primary care. You can't just come in as a GP. So I come in with an array of skills. I set up a coil clinic. I set up a menopause clinic at my private centre with 9 of the GPs. And also we offer an out of hours service as well. So patients can call us in the evening and we take that every evening on a rotational basis. And that means that we are giving a personalised experience. We still have clinical meetings. We still have palliative care registers. We are still paying into our appraisal system, and we are still revalidated, and CQC is still assessing us. So the thing with private medicine is that you've got to look at your costs as well. So your indemnity does increase because you step out of NHS work. So at the minute, the government is covering your indemnity, part of your indemnity. Let me just correct that, sorry. When you work as a private GP, your indemnity doesn't. And also you need to then double check with your appraisal office how much NHS and private work that you do. If you do completely private work, you might need to get a private appraisal and pay for that. What we have done in our practice, because it's Dr. Now, it's been running for about 13 years and I've just been part of it for the last 5 years, is that the partners got together and we have taken out our own indemnity for all the doctors. So they pay part of it and we pay part of it as a sessional or a locum GP in that scheme. It's very variable, but I do think I think it's going to take off more as we go ahead into the times because there's going to be more demand. Patients, I'm sorry to say this, they hate waiting and they want to see a GP and they want to see the GP that they like, that they get on with, rather than see different GPs.
Thank you very much, Dr. Nighat, for that answer there. We have one attendee who's raised their hand. I'm going to allow them to speak now. If you can introduce yourself briefly and tell us where you work. I think you just disappeared. I was just about to click allow to talk and then it went. Okay, never mind. We will go on to, oh, hang on. It is back there.
Sorry, Hassan, I wasn't quite used to the system. Yeah, sorry, I joined you guys a little bit late. My name is Mohammed. I'm a regional clinical lead for the South of England for Virgin Care. And also a PCN CD. So, like I said, I joined you guys a little bit late, and just a couple of points that I picked up on in terms of what Dr. John Jagan said. In terms of the work, I don't think it has returned to normal at all, and I quite agree with Dr. John that the demand for locums will quite likely increase again. We, like Dr. John, have not reduced capacity in any of our services, though I have to say that recruitment has improved massively. I'm interviewing doctors on a daily basis as opposed to every other week prior to COVID. So there is certainly an increase in interest. A lot of the newly qualified doctors are already applying for jobs, even though they get their CCT in September or so, and offers are going out to these doctors at a fair rate as well. So the locums are still being paid what they were paid before COVID, and we have not tried to cut the market in any way. And likewise, salaried doctors are receiving the same BMA contract that they were receiving before. So in that sense, there is a change in the market. However, I would say that there is it is worth noting that business as usual has not resumed. Although NHS England will send out directives, for example, restart your learning disability checks or your mental health care plans, that sort of work has not resumed necessarily. We have a massive backlog of nursing areas, for example, smears. That has certainly, we're way off target at the moment, given the fact that everything came to a halt quite rapidly. So I guess the one thing I would like to pick up on is, I think one of the panelists mentioned contributing productively to the practice, and I think that might have been Rachel. But in terms of what can a locum do, from my perspective, in terms of appraisals, we appraise and peer review our locums, regular locums as well. So and it's the same standard protocol, same standard template for peer reviewing all clinicians. So where do our locums differ in terms of their productivity compared to our salaried doctors? I would say the biggest area where I struggle with locums is that is the continuity that they're willing to provide for the patient. So there is something to be said for a salaried doctor is going to say, come back and see me next week, next month, because they know they're going to be there. And that often doesn't really translate with locums because they're not sure whether they'll be there next week or next month. Secondly, there's usually a significant discrepancy between the quality of care, and I use my words carefully, in the sense that if the patient came in for their I don't know, exertional dyspnea, then that's absolutely fine to deal with that. But what we often get, and we're able to build up with our salaried doctors over a period of time, is to address cough areas, to address other areas of the patient's care, which often comes through after a year or two of a doctor being with us. And you can't build that with a locum. So we all have the skills to be able to address other areas of patient care holistically, but the habit of sort of dealing with just the problem that's in front of us. Now we have 10 minutes to do that, so it is a big ask. It doesn't always happen, but I think there is something to be said for the quality of the consultation will make you more employable, and that's probably something that needs to be focused on.
Thank you very much. I think Doctor there, really appreciate your input there. We have many other.
Can I just make a little comment on that?
Go ahead, Rachel. Go ahead.
About continuity. So I think continuity is not necessarily linked to your working contract. So I think it would depend on how you're contracted, how your contract works. So I think to say that locums don't know when they're going to be back again is not necessarily true, because if you're in control of your own diary, you know exactly when you're going to be back. And if you're working as a regular maternity locum or providing some form of regular cover to a practice, you know when you're going to be back and you take control of those consultations. So I think that is perhaps to do with the way in which those particular locums are contracted to that particular company. And that's some of the things about quality that we're trying to encourage for locums, and that locums should be trying to encourage for themselves. And that's the sort of thing that I'm talking about when I say do a good job. So helpful. Thanks.
Fantastic. We have a number of questions here. I'm going to direct to Dr. Jagan, John, on this. Around e-consultation and trying to understand how people can get up to date with the skills. You know, I think things are changing. They're worried about the skill set. One saying, I haven't worked for 3 months. How do we prepare for remote and e-consult? And a few others are asking, as a locum GP who has not had a lot of work during the pandemic, how can I get training on the new digital methods of general practice, video consultations, etc. So I thought we'll answer a few of those kind of questions together. If I can direct it to Dr. Jagan initially.
Sure. So actually a lot of people have done, a lot of organisations have done, RCGP have done a module on e-consultation and video consultation. The BMA have also done something. and Rachel, correct me if that's correct, but they have done some consultations, and believe it or not, even our organisations like MD Medical, Red Whale, they've also done modules. Even Pulse, I understand. I haven't checked the Pulse one, I've checked everyone else. Even they have some modules that can be helpful for that. Most GP practices were given, or most areas were sent to every GP practice how to do video consulting and so on. So some of the practices that you may work with or work for, they will also have that resource because they use it for their own training in terms of where to go to. So if you're really unsure, even the CCGs or the STPs, they have a resource of where to get that kind of training going forward. I haven't seen as of yet the interview, and it's probably something that I need to look at, but I have never really, we recently interviewed another locum, I think last week. I actually didn't ask them because the assumption is, so it's a good point, I haven't asked, but I do think there is a lot of resource out there. Because it came in such a quick manner, people have done a lot of work to help support primary care, and even nurses also have video consult by the RCN. They've also done something. So there is stuff out there.
Okay. Thank you very much. I'm going to direct this question to Dr. Nighat now. I am a locum GP. I went on maternity leave in December. I feel very out of depth, worried about job prospects. Most of all, getting used to post with primary care consultations, remote video. How do I get up to speed with things? Thanks.
Oh gosh, I feel your pain being a mum of 3 and my youngest is 2, so I was exactly in that boat not too long ago. Firstly is don't panic. There's lots of modules on the Royal RCGP website that you can tap into. Actually, your indemnity, whichever indemnity you use, so I use MPS, they have lots of modules that you can go into again. And just on Jagan's point, that they also offer video and telephone consultation advice, because that's actually beneficial for them to know that they are training up all their applicants in regards to covering them for their indemnity. And the other thing is form groups with your friends. That's really useful. We forget that, and there's no shame in saying that I don't know something or I feel out of my depth. You'll find that you're not on your own. If you've got a first 5 in your local area, which we used to have set up by the RCGP, then tap into that and speak to your friends. We used to, all of us friends who were on maternity leave at various points, we actually formed a group together and used to go through guidelines and learning modules together. So yeah, there's a way of doing it. And there's so much on social media. I think that's the other thing that I haven't picked up on yet, but there's amazing teaching stuff on Twitter, social media, LinkedIn, that you can just get quick bites, because as a mum, I know you don't have time to read the whole module or do the whole thing all in one go. So click into the Royal College of GPs. They send out quick things on Twitter. The Royal College of Obstetrics and Gynecologists, they also do that as well. The DFSRH, they also send out, for example, how long the Marina core should be in for, and they update little bits like that. And NICE as well, they've got their own Twitter page and LinkedIn page, which you can go into and click into very quick advice for. So yeah, don't be shy.
The other bit of advice I'd offer is about induction. So making sure you've got a good induction into the practice is really important. And my colleague Paula Wright in the Sessional GPs Committee has done some really good YouTube videos on that. So if you search on YouTube for Paula Wright, it's spelled Paula, but it's pronounced Paula. You'll find some really good, useful, locum-focused videos about induction.
Thank you very much, Rachel. So there's a lot of talk about telemedicine. So I've seen a few questions come up about telemedicine. I'm not sure who would be best placed to give us some more information on how things are changing in that area. Dr. Jagan, go ahead.
Yeah, so definitely we are exploring. So remote monitoring and telemedicine is becoming quite a big thing for us. There is a lot of software out there. I'm certainly going through lots and lots in London, going through lots and lots of different software. But the good thing about a lot of software, they do have modules that come with it to how to use the remote software, how to use it in clinical practice going forward. And the biggest issue is quality. There's a lot out there, and it's just trying to understand what's good. But certainly remote monitoring for chronic long-term condition patients, it's not something that is new. It's been there for a while. Certainly in America and in some of the European countries, they've been doing that for quite a while going forward. So it is coming. It is definitely something that we're all looking at going forward. And interestingly, how general practice is a real debate across nationally about how general practice will use remote monitoring, particularly in care homes and things like that. That's something that we're looking at.
I can add a little bit to that.
Thank you, Doctor. Go ahead, Dr. Munshi. Go ahead.
Sorry, yeah. So my previous role was one-on-one clinical lead, and it's probably going back 3 years ago. We're looking at video consultation and how the one-on-one service could use video consultation to improve outcomes or reduce ambulance conveyancing. What it really showed to me was that in the right hands, don't get me wrong, the technology wasn't quite there probably about 3-4 years ago, but in the right hands, a clinician can make a significant impact on the outcome. And I think what every doctor is going to ask themselves now is that, you know, employers can be a lot pickier, so they're going to look at outcomes, they're going to look at conversion rates. The one-on-one is questioning these things. The one-on-one in our locality, the urgent care providers are. So it's about being safe, but it's about not making completely risk-averse decisions. It's about working at top of clinical license and to embrace the technology to get the safest, most appropriate, but also most appropriate decision, but something that benefits the system. Because we've got to stop working as individuals. We've got to start working as a system, and you've got to look at the impact of your decisions downstream. These are the kind of decisions that I think people will start looking at, you know, strong decision makers and saying, look, this guy is supporting the outcomes from one-on-one, is supporting the outcomes from the urgent treatment centre, is supporting the ED. And that really starts at primary care, because a lot of questions are being asked about, you know, where are we getting the highest number of referrals to ED? And I'll be honest, you know, we do audits on GP letters, and, you know, I've been a locum GP, so I don't want to take anything away from my colleagues here, but some of the higher referral rates to ED with a very low threshold comes from let's say a minority of locums, but it's noticeable. So these kind of outcomes we need to start as a profession looking at our outcomes and saying, you know, how do I optimize how I work? How do I get the best outcomes? I think there's something about upskilling yourself. So, for example, if you have areas of weakness, then you need to go out there and say, look, how can I get better at say managing X, Y, or Z? Because it will certainly make you more employable in the current climate. Certainly in the space that I'm in, because we're looking at good decision makers. So I think it's about embracing the technology, finding any gaps in your knowledge, and then trying to tie that together to make yourself more employable.
Thank you very much.
I completely agree with that. But I think one of the difficulties is the feedback loop. Sorry.
So just 1 second, Dr. Nighat, I believe you need to head off now.
Oh yes, sorry.
Dr. Nighat, sorry, you need to unmute yourself. Sorry, unmute. Can you unmute? Sorry,
yeah, thank you so much for having me, and for any of the panelists, the people who have joined. If there's any questions, I'm very accessible on social media, so at Dr. Nighat Arif. I'm more than happy, because I know how scary it is at the moment, but I promise you, to everybody listening, you're not on your own, and we're all in the same boat, and we will muddle along together, I promise.
Big thank you to Dr. Nighat for attending today, and good luck with your work and also your BBC and television radio contributions.
You can call me up on it if I ever do anything wrong.
That's constructive feedback.
Bye-bye.
Thank you very much, Doctor.
Sorry, what I was just saying was, I think the problem is sometimes getting feedback to locums. So if you are a locum and you have and you have a weakness somewhere in your skill set, often that's never fed back to you in any effective or supportive way. So it's incredibly difficult to ever improve that. And I think that's something that we have to take ownership of as a system. And it's something that's been a problem for years and years and years. And it's something that nobody's ever grasped. So I think that's something to think about as a broader issue.
Rachel, can I just make a comment on that? One of the things that I was thrown back with a locum GP who came in and said, look, I'm happy, you know, blah, 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 I'm happy to be here and all these things. And he just straight away started, look, I really welcome some feedback quite early on. And I was really thrown by that, because that was the first locum that ever said that. And he was only doing a holiday cover, but it really did throw me. So I do agree, it threw me as a partner. So and that really, I actually took a shine. Well, he's employed now, so.
Okay, so there's a couple of questions now. I'm going to pose this to, I guess all three of you can contribute on this particular aspect. A few locums have asked about AMP and nurses impacting on their work. So one's asking, do you think AMPs have taken our work? Another's saying that, where is the other one? Saying that centres are employing more AMPs and GPs are paying the same hourly rate. This is very demoralising. And there's a huge problem with workforce management. NHS is applying for GPs, but when you get out and look for jobs, there's very little. And they're saying that some competition is going with AMPs. So what's your response? I'll start with Dr. Munshi, and then we'll go to the others.
So we as an organisation have we've got a growing workforce. I think Jagan, who's on the call here, will agree that we've got a transformative process going on right now, where we've integrated with the community trust locally. So we've got a big nurse practitioner workforce coming in. I think that what you've really got to ask yourself is, and I keep reminding a lot of my colleagues, if you are not adding more value than the nurse practitioner in the service, then why should the employer be employing you? Now, I don't think that's true for all of our locums, but we see a percentage of them that are not making a higher clinical level of decision than the nurse practitioner. And I guess this is where the employers are saying, well, actually, if you're doing what the nurse practitioner does with the same outcomes. Now, the flip side is, if the employer is not looking at the outcomes and is not concerned about the outcomes, then how do you get around that? And that's something I ask myself. It's difficult, because if a nurse practitioner, and this is not an anti-nurse comment, but if a nurse practitioner has, you know, 1 of 4 outcomes or 3 outcomes, how do you monitor that? And that's really the employer's responsibility, to make sure that the outcomes are positive, both for the patient and the system. And I guess that GP practices, urgent care providers, 111, more and more questions will be asked about the outcomes, because we're trying to minimize the duplication, number of touch points, and repetition in the system in the middle of a pandemic. So we're going to be asking these questions. We want to get the patient to the right place first time. And I guess a lot of you could start asking the question that, if the nurse practitioner is sending patients repeatedly to ED and they've got a higher referral rate to ED or urgent care, and the GP has a significantly lower outcome, then that's something that you might want to, you know, audit and demonstrate to prove your worth, in a sense. I know it's difficult as a locum, but I think this is the way the conversation should go. So what I did as an urgent care lead to highlight the importance was, I highlighted the conversion rate of doctors to nurses to ED, and it was quite clear that our good doctors, their conversion rate to ED was significantly lower. So I proved that, you know, the system. Then I went back to the CCG and said, and the STP, and I said, look, you know, it's costing you X amount per ambulatory referral, X amount per ED referral, and by employing the doctors, you're improving the financial outcome, which is one of their big concerns, without compromising safety. And therefore the value of the doctor was then highlighted. That's the kind of work that we did locally. I don't know how you do that across the system, but that's how you differentiate between the nurse practitioner and a doctor working at the top of his clinical license. And that term I keep referencing, top of clinical license, is something used more frequently in places like the States. And there's more and more of that discussion going on now.
Thank you. Can I ask the two to very briefly add to that, if you can, starting with Rachel, Dr. Rachel?
Yeah, I mean, I agree with pretty much all of that. I think it really is about adding value, and as an individual, it's probably to say things like, remembering that you were going to be thinking about conditions that the nurse you'll be considering in your differential diagnosis, conditions that the nurse practitioner's probably never heard of. So making sure you document that, document your thinking, using investigations cleverly, not sending everyone for investigations, using them sensibly, thinking about what investigations are going to be helpful to you, thinking about drug interactions, and just really documenting things at a higher level. So thinking about kind of biopsychosocial things, thinking about your social interactions, how is this interacting with the rest of the world around them. So thinking broadly and using your medical training rather than the nursing background to add value. I think it is about adding value.
Dr. Jagan?
So I do agree that I can understand why the locums feel a bit pessimistic about this. There is this perception, I will be blunt about this, there is pessimistic that there is this thing in some of the practices that ANPs can replace GPs. There is. I've certainly been through many conversations where ANP, it looks like the low-cost GP. But like Sarfaraz has said, and Rachel, we do see it the hard way, that we find that actually the GPs, doctors do have their role. ANPs are great. I'm not questioning their role in the wider system, as Sarfaraz says. But certainly, I think you'll find that a lot of the people go full circle and realise that GPs are actually the most cost-effective option, simply because the breadth, as Rachel, I really agree with that, the breadth of what you do, and also the skill levels in terms of, because some of ANP work that I've had to look at is very protocol-driven. So something slightly different throws, and a lot of the ANPs require supervision. So whereas, you know, generally GPs, even locums, they just need a bit of support, someone on the end of the phone, or at least some kind of support. So I think you're right to call that out. There is this perception, but I think any organisation that's been through that, like Sarfaraz has, will know that actually there is a place for everyone, certainly with demand. So I would say that look to another organisation, because the ones that have been through it, like my own, I've got 4 AMPs in my practice for 8 GPs, so 8 locums. So just to give you an idea, so as well as 5 partners. So it just varies, and the locums are actually just flexible work. They just like working flexibly, which works for us.
Thank you very much, Doctor. Now we've got a couple of hands raised, so we will get to both M and Aksa Ali. So if you can just hold on with me, we're going to be finishing up very shortly in a few minutes' time with closing comments and a poll. But one of the contributors asked to get involved in this discussion. I believe he believes he can add some value. So firstly, M, if you can come on again. I will bring him on. I think you can speak now.
Yeah, should I, am I okay to speak?
Yeah, go ahead,
Yeah, just a couple of points. In terms of the workload that is shifting towards ANPs and nurses, we still have a contractual requirement to provide a certain number of GP appointments. So that number on APMS contracts, we certainly do. GMS has a bit more flexibility. So we're still providing the same number of GP appointments. And secondly, COVID has not been the reason for the shift of workloads away from GPs towards allied health professionals, but instead it's only been an accelerator. So this work was going on in the background of upskilling allied health professionals, whether that's via primary care networks or other redesign projects. That was happening anyway. What we should be probably focusing on, or what I would advise locum doctors to focus on, is upskilling themselves to aim towards being better leaders. So we don't need doctors to do asthma reviews. We need doctors to overlook respiratory care of patients as a leader. So that upskilling was happening, but COVID has only been an accelerator in a sense.
Thank you, Dr. Mohammed there. So now we'll ask the final question, and then we'll move on to closing comments and the poll from the panel. So we will, Ali, if you can go ahead, if you can introduce yourself and tell us where you work. Ali? Okay, they've got their hand raised, but maybe it could have been a child or somebody who'd done it by accident. Okay, so let's move on to closing comments. And while we do that, I will quickly open up a poll. Yeah, if we can start with Dr. Rachel, any closing comments, any closing pieces of advice for all the locum GPs on what they should do in the coming weeks and months?
I think one of the key comments that's kind of been in the Q&As that we haven't really picked up is about how vulnerable GPs are feeling at the moment, and I think it's really important to acknowledge that. It may or may not continue to be like this, and I think the only thing that we really know is that everything's going to be really uncertain. So I would encourage people to reach out to colleagues, to reach out to things like the BMA's counselling service. If you're feeling uncertain, you're feeling lost, you feel like you're struggling with how you're coping with this situation, whether that's just with how you're coping in general or how you're coping with the lack of work. So really reach out to people, reach out to colleagues, reach out to the BMA's counselling service if that's something that you need. It's free of charge to all locum GPs, whether you're a BMA member or not, or to your families if they feel that they need support. So just give the BMA a call if you need to.
Thank you. And Dr. Jagan?
No, nothing really to add. Just to say, you know, obviously it's difficult times, and I appreciate that, you know, the strength of the feeling in the group and the chat. I think I will say general practice isn't going anywhere, and certainly it still remains the jewel of the crown of the NHS. So let's never forget that as a profession, we are a well-needed resource in this country. Otherwise, the hospitals will just collapse. I will tell you that now. So I think in the end of the day, if, you know, I mean, I've learned a lot, you know, from our panelists, and I've learned some things from our colleagues who are on chat about some of the frustrations they have. And it's certainly something that I will take back in my patch to do. So all I can say is that keep the faith. I think we will get out of this period, and I think I'm hoping the optimism will stay, and we will, you know, you'll stay safe, and hopefully you will find the work that you need.
Thank you. Just quickly before we go on to Dr. Munshi for closing comments, there's a typo in the poll. It says how useful did you find this poll? It should say how useful did you find this webinar. So I do apologise for that. So please do complete the poll. 63% of you so far have completed it. And finally, Dr. Munshi.
Yeah. So I guess if we look across all the different professions, every profession is being hit hard by COVID. I guess apart from your profession, Hassan, which is IT, you're probably in big demand right now. But I think of all the professions, we're probably going to be, overall, we're going to be least impacted. So that's the positive side of things. How long it takes to get back to some sort of normality depends on how the virus behaves. You don't need me to tell you that as a doctor. You know, I feel the frustrations of my colleagues, and I think that, you know, we need to be optimistic. I think there's some good points made. By no stretch of the imagination am I an expert on how locums should what they should do next, but certainly upskill yourself. So when the opportunity comes, you're ready to grasp it. That's the way I look at it.
Thank you very much. Thank you for our fantastic panelists and for all the attendees. We had a very good, excellent attendance today. We have a few of you haven't finished this poll. Please complete it. That would be great. If you want to stay on for a minute, you can see the results. One of the topics we're asking, one of the questions we're asking is what topic you would like a future webinar to be about. That will give us some guidance on what kind of panelists and the topics we'll be discussing in a future webinar. So thank you everyone for attending, and we look forward to seeing you again.
Hassan, can I add a point? Are people looking into their local 111 CAS service? Because with London, there's a rapid expansion, and I suspect it's going to be the same across the country, or sooner or later it may be. So that might be one area that a lot of the locum workforce needs to start looking to, because it's an easy way to upskill yourself as they digitalize themselves with video consultations. So it might be one place to go.
I thought Dr. Rachel, they're disagreeing with you.
There's been horrific problems with locums trying to get on stream with it. So that despite there being alleged massive gaps in demand, there isn't, that locums haven't been able to get it. So I've got a colleague who has had no work at all for 3 months, and who has been chasing and chasing and chasing and chasing to get on CCAS for about 2 months of that, and has got no shifts at all, despite there being gaps. And that's not one person, that's multiple people. It's hundreds of people who are in that situation. And somebody has written, yeah, in my area, it's been decommissioned in the northeast. Of the northeast, CCAS has been mothballed because of local.
Sarfaraz, I think that might be a London thing, Sarfaraz.
Yeah, I think so.
Okay. Well, there's some regional differences which we've
There's a regional difference for you.
We were discussing that just earlier on. Very finally, before I end the poll and close, any feedback you've got, do feel free to message me on LinkedIn or email me, or even call me if you get my phone number, or you can call or contact us via the website, pairoo.com. I'll end the poll now, and please, if you have any feedback, that would be fantastic. Thank you, everyone. Thank you to the panelists, and have a great evening.
See you later.